Hello, welcome to Chapter 22, Respiratory System Infections. This one's a big one, guys, so get your coffee. Respiratory system is extremely common to get infected because of several things. The way that it's spread can be through just talking to someone, right? So the virus is going to be part of our respiratory system, which is, of our mouth and nose. So any secretions from our mouth and nose can cause transmission. Sneezes, coughing, singing, kissing, obviously, are just ways that someone can get respiratory infections, and it can be over longer distances than direct contact. Also, the respiratory system is very delicate, especially in the bottom of the lungs, right? So the upper and lower respiratory system has defenses, but since our respiratory system, especially near the alveoli, right, we have very, very thin tissue, and the bloodstream it's very well vascularized because our blood is there to pick up oxygen and to release the CO2. So pathogens that make it down to the alveoli are able to get into the bloodstream, and it's just like very delicate tissue to infect. So many respiratory diseases. So we're going to start off with the anatomy. For the upper respiratory tract, it's basically in our head, right? Our head and basically almost to our throat. We're going to have the nasal cavity and the oral cavity. And there's an image of your ear here because it is connected by this tube that leads down to your, basically the back of our nose. So let's look at this. This is the nasal cavity. This is obviously the opening to our nose. It's, we call it the nostrils, but the technical term is nares. We have our oral cavity, right, the mouth. If you go straight back to the back of our nose, this little area here is going to be called the nasopharynx. And the opening here, right, it's going to be common area with the back of our mouth. That's called the oropharynx, right? The oropharynx. And then the region, if you go a little bit longer down here, the region that is going to be right before the split, if we see here, this is the esophagus, okay? That's going to go to our stomach. And then in the anterior part, right, in this part, this is going to be where the air goes. That's our trachea. So in this area, right before the split, is going to be called the laryngopharynx. So the word pharynx is just a term that refers to this, you can think about it as throat, but it encompasses this common passageway for both air that's breathed in and also the food that we intake. That's the pharynx. And the pharynx can be split up into three sections: nasopharynx, oropharynx, laryngopharynx. Now, the it's the eustachian tube, maybe you've heard of that. It's also called the auditory tube. But there is an opening right here at the back of your nose that leads to the middle of your ear. So remember, there is the external ear, the outer ear. We looked at an infection here. It was called swimmer's ear. It was called by Pseudomonas aeruginosa that causes an infection here. Middle ear infections that we're going to look at in this chapter are basically due to the fact that because we have this connection point from the respiratory system all the way up to the middle ear, that can cause your middle ear infections. Sometimes we just say like ear infections, but we really are meaning these middle ear infection. And then the next part that's kind of grayed out here, that's your inner ear. We're not going to really talk about that at all. But the middle ear is it's air filled. Okay. And the reason why we have this tube is to equalize the air pressure from the outside air with the air pressure inside our middle ear, because that air pressure needs to be exactly the same in order for our eardrum to vibrate properly. So you might have experienced like going up in altitude in an airplane or maybe down lower, and your ears will become like clogged or stuffed feeling, right? Then you quote unquote pop your eardrum, and then you can hear again. When you pop your eardrum, you're actually just opening up this eustachian tube, because this is kind of a closed off tube most of the time. So when you open your mouth really wide in a yawn, or when you swallow, it helps to open up this tube and it equalizes the air pressure instantly. For microbiology, it is a pathway for bacteria, right? So the upper respiratory system is well stocked with normal flora. It's all mucous membrane. And so there's going to be lots and lots of bacteria that harbor our mouths, that harbor their nasal cavity. And these bacteria are the ones that commonly come up. They go into the eustachian tube and they can infect the middle ear. But basically, we just want to talk about this, right? So we have our nose, our oral cavity, the pharynx. And so that's the upper respiratory cavity, or sorry, upper respiratory tract. And then the lower respiratory tract we consider from the larynx down. So the larynx is where you're going to have your vocal cords. It's also going to be the area where we have that initial split, esophagus and trachea. We can also see that the trachea is the initial tube that goes down into our lungs. It will split. And when it splits, those really big airways are called bronchi. The word bronchus is plural. And when those air passages get really small, they become bronchioles. And those bronchioles are going to then split and split and split. And then they are formed tiny, tiny entranceways leading to our alveolar sac. So you want to know alveolar sac. So the alveoli, right? If you think about alveolar sac as a bunch of grapes, an alveolus, one, is just one of those bubbles, okay, one of those air sacs. So the air sacs is where gas exchange occurs. This is what I was talking about, it being very, very delicate, very thin tissue, because we have to have gas exchange occur instantly. We have all kinds of defenses against respiratory infection, but of course those defenses can be overwhelmed. So in a defense, for example, here is going to be our resident macrophages. So inside of your alveoli, even though it's very, very thin, there will be some cells sitting there that are literally macrophages. And they're there in case anything doesn't get picked up by the mucociliary escalator. Remember that mucociliary escalator was the lining of your nose, your pharynx, all these really big tubes of the lungs, like your bronchi. They're going to contain cilia, and when you breathe in, the mucus that's produced in these areas will trap the particulates and the it can be viruses, bacteria, mold spores. They're trapped, and then your cilia, right, will move it up to this part of your throat. And so it's imperceptible that it's happening, but every time you swallow, a little bit of that mucus goes into your esophagus and it's destroyed in the stomach. So it's that mucociliary escalator really protects us from a lot of those larger microbes that can get stuck. If the microbe does get down to the alveolus, we do have another, those macrophages are the last basically step to the immune response. So because the mucociliary escalator does such a good job, the lower respiratory tract is nearly sterile. So all the bacteria, the normal flora that's in your mouth and your nose, don't generally make it into your lungs because you have that mucociliary escalator. And just like little fact, smoking, cigarette smoke in particular is very toxic to the cilia. So remember the cilia on your cells, right? They were long little attachments, right? And they actually move, right? They beat and they help to move things across the surface. And so when you have cigarette smoke or any other toxin and smoke in general will basically destroy these cells, and the cilia goes away. When the cilia goes away, all of a sudden our mucociliary escalator doesn't work as well, and people get more lung infections, right? So if you have smoker's cough, or smokers, they will often get more respiratory tract infections than people that do not smoke. All right, so what normal flora do we have? So I already touched on this, right? So our nasal passages and the pharynx can be colonized by lots and lots of bacteria. It's a varied population from person to person, and also, for what that contains. So most commonly, Staphylococcus epidermidis. We have our viridans strep, which is the strep that, if you remember from lab, we took a throat swab and we looked at the blood agar plate. The viridans group is alpha hemolytic. It does not completely lyse the red blood cells, but it does sort of make little holes in them. There's something else called Corynebacterium. This is something we're going to talk about with diphtheria. That can be found as normal flora. Haemophilus, remember this was the bacteria that caused pink eye. It can also cause infections of the respiratory system. And just that our star pathogen, right, Staphylococcus aureus, 20% of the population carries that in their nose. The throat can be colonized with Strep, Haemophilus, Neisseria, and many members of the respiratory system. The normal microbiota are simply referred to as opportunistic. And then here are our basically defenses, right? So mucociliary escalator, and then the macrophages. So I thought I would show a little mucociliary clearance.
The air we breathe contains foreign matter such as dust, bacteria, and pollen. Hair-like cells called cilia, as well as goblet cells, can be found in the lining of the respiratory tract called the respiratory epithelium.
Or it could be pollen, or it could be mold spores. It doesn't really matter.
Goblet cells secrete viscous mucus that forms a layer to trap foreign material. The wave-like action of the underlying cilia mobilizes the mucus layer, removing the foreign matter and preventing it from entering the lungs.
Evolutionary trick that you have in our respiratory system. Okay, so what kind of symptoms do we have when our respiratory tract is infected? Most commonly, it's rhinitis, which is basically a runny nose, right? It's also associated with hay fever, so allergies and other irritants. So any sort of chemical, maybe it's smoke from a fireplace, but that can cause your nose to run. There's also your sinuses, and that's called sinusitis. So let's actually go back to that first picture. So I can show you that there's a couple sinuses visible here. There's the frontal sinus, which is a cavity in your bone. And then there's the sphenoid sinus, which is another cavity in your bone. These sinuses are air-filled and they're lined with mucous membrane and they're connected to the nose. So if you have bacteria that can enter into these sinus cavities, it can cause infection. Pus can fill up and you can get, a lot of pressure in your forehead. Maybe you feel it behind the eye. There's another big sinus in your cheeks. So you can feel pressure like below the eye as well with sinusitis. So back to this picture or back to this slide. That's sinusitis. Middle ear infection is otitis. Pharyngitis is just sore throat, right? Pharyngitis is the inflammation of that pharynx. And inflammation of the larynx, where your vocal cords are called laryngitis. And you know that laryngitis, people tend to lose their voice because the vocal cords get big and inflamed, and it's not going to vibrate as it should. All right, some images of the respiratory tract infections we'll be looking at. This is a sore throat. It's a very sore throat. It is scarlet fever caused by Streptococcus pyogenes and the accompanying rash that comes with it. This nasty guy here, this is called just by diphtheria, or the disease is called diphtheria. Corynebacterium diphtheriae is the causative agent, and the hallmark is a patch of just dead cells and lots of exudate, forming a membrane across the throat. Here are some images of the eardrum when it becomes inflamed, and then this is going to be some x-rays of the chest. Normally, x-rays of the lungs should be black because the x-rays just go right through that really delicate tissue. But if you see areas where it is white, that means that the substances there are harder, more solid, and they're going to take up that x-ray and it'll show that. So this is not going to be normal on the lung, and it shows, I think this is tuberculosis. All right, so we want to start off with some vaccines. I know that there's a lot of vaccines, but you should know them. So some of them you've heard of before. There is a vaccine for chickenpox. Okay, it's called the varicella vaccine. There is no vaccine for the common cold because it's caused by so many different viruses. There is diphtheria. So diphtheria is DTaP. Sometimes it's written different ways. Diphtheria, acellular pertussis. And then this is HIB for Haemophilus influenza. This is the flu, right? So there's a couple of ways we can vaccinate against the flu: a shot and a mist that goes up your nose. MMR, measles, German measles, and measles, mumps. We don't have mumps here, but measles, mumps, and rubella. Then we have pertussis, so that's whooping cough, and that's in the DTaP vaccine. So acellular pertussis, that P is for whooping cough. Then we have pneumonial vaccine. We have that rubella. There's no vaccine currently for lots of this severe acute respiratory syndrome. This is different than the COVID that we're experiencing. And then tuberculosis. There is a vaccine, but as mentioned before in previous chapters, we don't currently vaccinate in the United States for the tuberculosis because it's not common enough to do it. And also it is a not very efficient or efficacious, vaccine. Doesn't work that well. Okay, so here are bacterial infections. I think that, let's go through one at a time. The first one is going to be strep throat, and scarlet fever and rheumatic fever. So all of these diseases are caused by Streptococcus pyogenes, and they're all sort of like related. So lots of people get strep throat. Strep throat can lead to scarlet fever. Scarlet fever can lead to rheumatic fever. So we'll take a look at that. Okay, so Streptococcus pyogenes we looked at in the skin. This guy is also going to cause our respiratory system, mainly just the throat. So we have streptococcal pharyngitis, otherwise known as strep throat. Strep throat can be really dangerous because there are those two diseases that can follow. So it is treated aggressively. The toxin it produces is called erythrogenic toxin. And this toxin, so we're going to see a couple of these, is encoded by a temperate bacteriophage. What is that? So back to this picture here where we covered in the beginning of the semester. Here's the phage, right? This is a virus that only infects bacteria. Remember that the phage's DNA can incorporate itself into the bacterial DNA. So if this bacteria was Strep pyogenes, Strep pyogenes, it did not have that erythrogenic toxin, but the virus gave it to him. So the virus actually coded for erythrogenic toxin. And so now the bacteria has it, and every time the bacteria divides, right, we know that that prophage remains inside the genome and is copied in all the daughter cells from that first infection. So that is how this exotoxin is given to certain strains of strep. And the toxin attacks plasma membranes of the capillary endothelial cells. What is that? That's just the lining of our capillaries, and that can cause scarlet fever, a systemic disease. What you see here in these pictures is scarlet fever. It's not strep throat. Strep throat is going to be a very sore throat, very red, very sore throat. However, when you have it continue and it spreads, then you have a red rash on the skin, and also a very hallmark feature of it is this strawberry tongue. That is a sign of scarlet fever. And here's another, so this is rheumatic fever and acute glomerulonephritis. So the word sequelae, it kind of looks like the word sequence, right? So, or in the series of, so basically this is what can happen, basically later consequences. This is the definition, later clinical consequences of a primary infection. So strep throat, again, is treated aggressively with antibiotics because they want to prevent scarlet fever, and they also want to prevent rheumatic fever and acute glomerulonephritis. I was thinking I misspelled that. Rheumatic fever is where the microbe, right, this bacteria, causes some kind of autoimmune reaction to the heart tissue. So something on the surface of the strep pyogenes, they don't really know exactly how, but it makes your immune system recognize heart tissue. And so that's what happens, your autoimmune reaction and your rheumatic fever can damage and inflame the heart, and that's called carditis. You may have heard the word endocarditis. Endocarditis is just the lining of the inside of the heart, whereas just carditis can mean it refers to other areas of the heart as well. In this one, you can see that the valve is damaged with rheumatic fever, so that's pretty serious.
Another very serious sequelae of strep pyogenes is acute glomerulonephritis. Primary mechanism appears to be the formation of these complexes. So we have seen this before, right? So in our bodies, right, our B cells make plasma cells, they make antibody. The antibodies will bind to these green dots. That's going to be our strep pyogenes. And for some reason, this complex, right, the antibody and the antigen get deposited in the tissues of our body. In this case, because the word glomerulo and nephra is for kidney, so it's going to be deposited in the blood vessels of the kidney, and it causes inflammation in those areas. So we can see that the immune complexes of the antigens for strep pyogenes, that means itself, and the antibodies against them are deposited in the glomerulus of the kidney. The glomerulus is going to be the area where your blood is filtered. So that is a really important place of our kidneys. It's basically the working filter of our kidneys. And if you have inflammation there, your kidneys are not going to be able to function properly. So it can lead to damage and inflammation of this area and subsequently kidney failure if you don't treat it. Here we have our middle ear infection. So ear infections are really common with kids and babies, most common between 3 months and 3 years. And this is because that eustachian tube we looked at earlier is much shorter in kids. So, the distance between the back of their nose and their middle ear are short, and they also drain slower. And also when you're laying down or you're feeding laying down, which kids do a lot because they take naps and they sleep a long time, it makes it more difficult for the drainage to occur. And so you sort of have slower drainage or clearance of anything that can go up that eustachian tube. So here again is that reference point. The bacteria can go from the throat into the middle ear, colonize the middle ear, and cause infection. The most common is going to be our Streptococcus pneumoniae and Haemophilus influenza. So we've seen Haemophilus before with our conjunctivitis in there on the eye. And Streptococcus pneumonia, I think this is the first time we've talked about Streptococcus pneumonia, but that's also prevalent in ear infection. So I want to show you these pictures. So this is a normal ear. If you were, if you had one of those otoscopes, those things that just look into your ear, as the doctor does in like a general checkup, your tympanic membrane or the eardrum should be nice and clear. This guy right here is the bone that is the malleus. That's going to be the first bone to transfer the vibrations into your inner ear. Here we can see the bone in white, and then there's some inflammation, and then here we see a lot of inflammation and pus. So depending on the severity, they may choose to put a little tube in. This is called a tympanostomy tube, and that is going to, the doctor will make a little incision in your eardrum, put this tube in, and it helps to drain the pus. That pressure against the eardrum is very painful, and it drains the pus. And then I had a friend whose child had this done, and she said it pushes it out. So as your eardrum heals, it will push out this little tiny tube and heal itself. All right, our next bacteria is going to be the disease is diphtheria, Corynebacterium diphtheriae. And we saw before that it is part of our normal flora. Some strains become pathogenic because of, here we go again, that bacteriophage. So it is the bacteriophage gave this Corynebacterium diphtheriae something called an AB toxin, called diphtheria toxin. So quickly, an AB toxin is basically a binding. So the A is the active part of the toxin, and the B is the binding part. So it's a 2-part toxin, and as we said, 1 part binds to the host and the other part becomes the active part. And that's all you need to know about AB toxins. It's just a way that this certain one toxin works. And like strep throat, diphtheria is commonly transmitted in the droplets and aerosols. And if you are unlucky enough to get this form of diphtheria where the virus has this toxin, it can create that gray pseudomembrane. So the toxin is going to kill lots of cells in the and cause this inflammatory response. And that grayish pseudomembrane we saw before is basically this collection of dead host cells, pus, red blood cells, white blood cells Fibrin. Okay, so fibrin is a protein that is part of your immune response. It's part of the, no, sorry, not immune response, it's clotting. So it is a clotting factor that forms, a blood clot, like when you start bleeding and your body can stop the bleeding. So fibrin is in there and it's very tough, and that's what sort of knits everything together. And so we're going to have a pseudomembrane. And these guys can get so big. You can see this picture over here. They can get so big that they can like block your airway off. So that can really lead to suffocation and death. So this is a pretty serious disease because of that. Another thing about Corynebacterium is that the shape of it is club-shaped. And if you look carefully, you can see that there are pretty much rods, but the rods will have like a wider, rounder end to them. So, that is the shape of Corynebacterium. All right, now on to our bacterial pneumonia, which is our Streptococcus pneumoniae. So it's really nice that it's, named after a disease that it causes. And like any pneumonia, is going to be caused by respiratory droplets, by bacteria in the respiratory tract. This is very common, normal microbiota. And of course, it causes infection when it gets overwhelms the lungs' immune system. So what happens first is that the bacteria will move from our respiratory tract in the upper area. Remember, the upper respiratory tract is where we have our normal flora, and the lower respiratory tract is relatively sterile. So first we're going to get down into those large bronchioles, or bronchi and bronchioles of the lungs. Bronchi, then bronchioles. Bronchioles are the smallest ones, the smaller airways, and then those lead to the alveoli. So this bacteria can get way down in there, and then the alveoli, as we remember, have those macrophages. But Streptococcus pneumonia has a really big capsule. So the phagocytes down there have issues. They have trouble with phagocytosis. And on top of that, there's some other virulence factors like autolysins that degrade the walls and then resulting in cell lysis. So they actually degrade their own microbial cell wall. But inside the cells, when the cells lyse, they release all of these virulence factors that were inside of Streptococcus pneumonia. And they can form pores, damage your own cells, the host cells, and it enhances inflammation and cytokine production. Inflammation, when you're down in the alveoli of the lungs, is not good because what you're looking at, right, your alveoli is an air sac, right? So it's a tube, and we have air coming in, and air swirls around, and it gets diffused into the bloodstream, which is nearby. So we can just draw a quick little blood vessel here, right? So what happens if there are lots of cytokines here, and those cytokines are drawing your lymphocytes into the alveoli, and it's causing inflammation and pus. Inflammation comes with that vasodilation and water leaving the blood vessel. If it comes in here and water starts to build up in the alveoli, then the gas exchange is going to be slowed down or stopped, because now the gas has to go through your basically pus, or the fluids in your lung travel through that and then to the bloodstream, which is going to impede the exchange of gas. So that is going to be really dangerous. So the issue with pneumonia, right? And pneumonia is different than bronchitis because pneumonia is specifically the alveoli. Okay, that's important to remember. When you talk about pneumonia, it is always the alveoli that are affected. When you talk about bronchitis, that is higher up in those larger airways. Bronchitis can lead to pneumonia, but it doesn't have to, and it doesn't always. You can treat bronchitis and it can go away. But that's the risk of pneumonia, is pneumonia can actually stop your body from exchanging gases, which is deadly. All right, so this is the exudate, right? The fluid that can build up inside your lungs. All right, so we can see from this chart, right? We have our strep pneumo coming in and colonizing the upper airways. Then the upper airways, the bacteria can go down and infect the alveoli. When the alveoli are infected, you have inflammation, which is where the fluid is coming from. And then because your blood vessels are right there, it's pretty easy for those bacteria to get into the bloodstream And then one serious consequence of this strep pneumo is meningitis. So there's another strain that causes meningitis, Streptococcus meningitidis, actually, that we'll talk about as well in a future chapter. This is basically what I was drawing, right? It's about the same. So we have this is the process, right? So we have strep pneumonia, autolysis, right? So it breaks its own cells apart. Interesting little trick. I don't understand the evolution of that. But when it does that, we have these toxins that can punch holes in our white blood cells. Actually, they also recruit more of these neutrophils, right? So their neutrophils are recruited in here. Now we're going to have a bunch of cytokines, a bunch of swelling, inflammation. The macrophages in here are trying to get rid of them, but they're impaired because there's such a nice capsule on the Streptococcus pneumoniae. And this activity of the cytokines and inflammation can actually kill the healthy cells of the alveoli as well. So normal alveoli should be nice and clear. Pneumonia is going to be filled with pus. And so again, gas exchange is going to be slowed, impeded, which is not good, right? All right, another form of pneumonia. So we're going to talk about 3 different pneumonias. This pneumonia is called by Haemophilus influenza. Remember that this is the normal flora of people and also many children. And it's spread the same way other pneumonias are spread, droplets or aerosols. This one is predominantly seen in the elderly because it is a little bit of a weaker bacteria. So elderly are more susceptible to get this kind of pneumonia. And yeah, so this infection results in inflammation and accumulation of fluids. So basically pneumonia, right? Inflammation and accumulation of fluids in the alveoli is basically pneumonia. The last one is something called walking pneumonia. This bacteria is called Mycoplasma pneumoniae. And mycoplasmas are weird. Mycoplasmas have this really strange shape to them. They have this pointed end and then like that. This pointed end is what is sort of sticks to the cells of your body. Walking pneumonia is also called atypical pneumonia, and it's not as severe. It's basically sort of a slow, semi-severe disease. It's passed because of this droplet thing, right? It's very common in crowded environments, college campuses, military barracks, often mild, right? With a low fever, persistent cough, but it's called walking pneumonia because you can get up and walk around. You might be able to do some work. You might be able to attend class, but it's just going to be, you're going to be tired and weak from it. Another interesting thing about mycoplasma is they do not have cell walls. This means that all those antibiotics that attacked peptidoglycan, like the beta-lactams, they are not going to be useful at all, right? So we have to choose other antibiotics. So we're going to limit the amount of antibiotics that we can treat this with. This specialized attachment was what I was talking about. This like little pointed end is the part that attaches to the cells. And they can damage that ciliated escalator. Because they don't have a cell wall, they are pleomorphic, meaning that their shape can take on different shapes because there's nothing rigid. And we talked about how beta-lactams do not work against these guys because there's no peptidoglycan. Self-limiting, meaning that it can go away on its own without any help, but also antibiotic therapy can help. All right, this is the big one, tuberculosis. So tuberculosis is caused by Mycobacterium tuberculosis. We did talk about this guy previously, and there are degrees of the disease based on your immune system, your immune response. So the immune response of infected individuals, like 90%, resolve, and they result in the formation of a tubercle in the lung. And the tubercle is, we talked about this before, there is basically the bacteria walls itself off in the tissue of your lung. And the mycobacterium here is going to be in this rod shape, and it's going to come in and it's going to wall itself off, right? Or the immune system will wall it off with proteins and, all the coagulates the immune response, fibrin, and basically create this little pocket of cells. So this is called primary tuberculosis, and the bacteria, it can be reactivated to form secondary tuberculosis, but only and usually in immunocompromised people. So first encounter, you might have a cough, low fever, and your body is busy putting these guys in little tubercles. So you are infected, but what happens is your body can either take care of it, get rid of the tuberculosis infection, or it stays in there for decades. It can stay in there for decades. It can stay in there for years, months. And then depending on your immune system, you can have these guys break out and then cause a secondary infection. So where do you find Mycobacterium tuberculosis? Humans. And so in the world, this is a big issue. About 1/3 of the world's population is infected with it. You infect it with respiratory droplets and aerosols. And you can see that these posters were actually posters from the United States when tuberculosis was very rampant in the United States. But we can see that the rates of tuberculosis have fallen a little bit, right? It fell, so it says tuberculosis disease cases increased in 2022, but did not return to pre-pandemic levels. So basically, it's still an issue in many areas of the world. This is just a larger look at our primary infection. Here's our alveolus, the macrophage. Here's the mycobacterium. Remember, right? What's it doing inside the macrophage? Well, remember, these guys are acid fast. And acid-fast bacteria have mycolic acid on their cell walls, and so they're very impenetrable to enzymes. It's like a wax layer on the outside. These macrophages will try and break it down with acid. They'll try and break it down with enzymes, but they survive. They get out of their phagolysosomes, and they can thrive inside macrophages. Okay, so they're going to freely replicate inside the macrophages. The dead macrophages release bacteria and they're engulfed by other macrophages, and the person can be either asymptomatic or have a very slight fever. So primary, it can mimic any other sort of mild respiratory infection. So then in primary tuberculosis, here's our tubercle. So we have infected macrophages will do their thing, right? They present to T cells, and there's more activation of the immune response, and the macrophages will form this tubercle around them. So trying to wall off the bacteria inside of this mass, and that's what shows up on the x-rays. All right, so other substances can be found inside this tubercle, such as collagen fibers. And so the collagen is also enclosed, and it forms a center that is like cheese, which is where the word caseous necrosis comes from. Fat and protein are released from the dead cells, and it becomes lovely, right? It's caseous necrosis. And then there's a stalemate, right? So this tubercle can stay inside a person's lungs for life, and not cause any other infection. And so the immune system prevents further spread, but does not clear the infection. Other people, if their immune system is compromised in some way or they're weakened in some way, the bacteria can actually break out of our tubercles, and you can see how close the bloodstream is because this is the lung, and very thin-walled cells to very thin-walled capillaries, it can have easy entrance into the bloodstream. So here's a picture of our breakage. And this is mainly observed with people with alcoholism, the elderly, and immunocompromised. So we have a reactivated secondary infection. So now what, right? It goes to other areas of the lung. It can go into the bloodstream. So secondary tuberculosis is going to be a little scattered because it can enter the bloodstream and different parts of your body can be affected. So here it says the majority of tuberculosis patients recover more or less completely from the primary infection, but the live bacilli can remain dormant and be reactivated weeks, months, or years later. They can also spread to the rest of the body via the bloodstream. Fluid, so because this is primarily a lung infection, fluid or air may collect between the lungs and the lining of the lungs, progressively destroying lung tissue. Coughing up blood or phlegm may occur. So this is where, if you watch movies and they have, a historical movie and they have people with tuberculosis, the hallmark of that is like coughing up blood. And when you do that, obviously the blood's going to have a lot of bacteria in it. So the bacilli may be released to the lungs, to other parts of the body. And then for the body, you have wasting. So people will get thinner and more frail because of the tuberculosis. And that's why it's also called consumption. It's the nickname they used for it because it consumed your body. So if you watch those old movies, they might refer to as consumption. And one interesting thing is Bloody Mary. So this is not even a test, but I thought it was fun. So Bloody Mary's name referred to her suffering from tuberculosis. So during meetings, since she was a royal person, she would cough up gobs of bloody mucus, and then her servants would take them away in their bare hands. And this is there's a painting that is, I'm dying to see this painting, but there's a painting that supposedly depicts this scene, but I haven't seen it. And this is her. She was the Queen of England during this time. So Bloody Mary, I don't know where the drink comes from, but that's the woman who got the name Bloody Mary from her tuberculosis. These are some chest x-rays. As I said, a nice chest, right? A healthy chest will have all black areas, just showing you that it's free of fluids and it's free of those nodules. And then we have this person here. We can see some growth within her lungs. So she had a dry cough for the last 3 and worsening health status. And then this guy is really previously treated for tuberculosis, but you can still see that his lungs are not clear of growth. And there's still, it can also cause like some scar tissue to build up. So this is the lung of somebody who has been previously treated. But you can see it encompassed a lot more of his lung than over here. And just to wrap up a little bit, reviewing what we learned in past chapters, how can you detect or manage tuberculosis? Well, here in the United States, we always do a tuberculin test, right? This is our PPD or Mantoux test because we do not vaccinate and it's not prevalent. It's not like a endemic disease here in the United States. So whenever you get a job, when you need to go to school, if you're ever going into a crowded environment, they will do a tuberculin test on you to make sure that you have, either have never seen the bacteria, never been infected. And if you have, right, if your test comes back positive for tuberculin, this, what does that mean? It means either you have antibodies it means you have antibodies or some reaction, memory. Let's not do antibodies because actually that test is based on T cells. So you have some memory, right, to the infection, the primary infection. And because of that, they're not sure if you have those tubercles. So then they need to do an x-ray because you could also, how can you also be positive? You can also be positive if you got vaccinated, right? So that's the BCG vaccine. So both of those, you would be positive. So they do an x-ray to make sure that your lungs are not harboring any tuberculosis nodules. They can do acid-fast staining with the sputum. So you would cough up the sputum and they could do a stain. Treatment is very long because the bacteria grows very slowly. And a lot of the antibiotics will target bacteria when they're dividing. And this is another mention of the BCG vaccine. Again, it's not very successful, has a very sort of low success rate, which is why we don't use it. And, we don't really need to use it because tuberculosis is not prevalent. But if you lived in areas of Peru where tuberculosis is all around you, you probably wanted to get the vaccine. And then here's that Mantoux test, also known as PPD skin test. All right, I'm going to stop and take a break here with whooping cough.